Good evening, everyone. Thank you for joining us for the next webinar in our Scleral Lens Education Society webinar series. Tonight's webinar is titled How to Create a Scleral Lens Masterpiece, Merging the Past, Present, and Future Technology. So we have two awesome speakers tonight coming to us from Canada. First, we have Dr. Sheila Morrison. Dr. Morrison studied at Pacific University College of Optometry, where she earned her doctorate of optometry, her master's of vision sciences, and she completed her residency in cornea and contact lenses. She then went on to serve as faculty at the University of Houston College of Optometry, and she now practices at Mission Eye Care Center for Dry Eye and Corneal Disease in Calgary, Alberta. While working there, she's also a clinical instructor for fourth-year optometry students that rotate from the University of Waterloo. Dr. Morrison enjoys lecturing throughout North America on a variety of topics, including ocular surface mapping, myopia management, and specialty contact lenses. Dr. Morrison is also a fellow of the Scleral Lens Education Society, an editorial reviewer for the Journal of Contact Lens Research and Science, and a board member of the Cornea and Contact Lens section of the Canadian Association of Optometry. Thank you so much for joining us. We also have Dr. Andrea Lasby. Dr. Lasby completed her Bachelor of Science from the University of Calgary, and then she went on to complete her Doctorate of Optometry at the University of Waterloo. She then went on to complete her cornea and contact lens residency at the Northeastern State University, Oklahoma College of Optometry. Dr. Lasby currently practices in Calgary as a partner at the Mission Eye Care. She's a fellow of the American Academy of Optometry and the Scleral Lens Education Society, and she currently serves as the president-elect of the Alberta Association of Optometrists. Thank you so much for joining us, ladies.
Thanks for having us.
We're so happy to be here, and we know that quite a lot of you out there are good friends, and we were just talking before this presentation started about how excited we are to get back on, out there again in person, and looking forward to some conferences to see you all in person again. However, at the end of the day in clinic, this is actually a really great opportunity for us to hop on and talk about scleral lenses for an hour with you. So we're very grateful to be here. As you know, things have really evolved over the past decade when it comes to not just scleral lens, but most specialty lens design. And really where we're at today is merging a few different things. So we always talk in our clinic about how do we merge science into what we do in the clinic. So that's the first thing that we merge. Now, today in 2022, we talk a lot about how to merge technology, using the things that we've learned in the past and putting together all of the tools that we have access to. Now, here's our disclosures, by the way, pop that in there. And, essentially kind of the theme of this is really that our final destination is really extraordinary. And we wanted to just share a few of our favorite clips from this past year of our travels. My image to share with you is Lake Carnarvon. So the mountain that you see on your left is a really crazy hike that I did last summer. So to get to this beautiful open mountain in Canada, so anyone that ever passes through, please contact us so that we can give you directions to it. It's a, tree climb, mountain climb, up over pulling up on chains, up over a rock to get into this beautiful landscape. And so this is a destination that I really enjoyed last year.
Yeah. And the only really interesting destination I've been to this year is I went to Western Kansas. And so I kind of thought that would be a very boring picture. So I put in my favorite destination pre-pandemic. So a few months before the pandemic, I was out in Italy. And so this is a picture in Pompeii. And so for those of you who have been out there and actually seen the devastation from the volcano eruption, pretty cool place to go. So highly recommended.
So those are geographic destinations. And here today we're going to talk a little bit more about our final destination being these beautiful, well-fit scleral contact lenses that we can create today. So we've seen changes, certainly over the past decade, due to increased popularity of the devices. We're seeing an increase in scleral lens fitters. Here are some statistics to kind of read over. Currently, the opportunities for continuing education on scleral lens fitting and topics related to scleral lenses has really exploded, evident by events like this and things hosted by the Scleral Lens Education Society. There are, countless ways that you can get yourself up to speed. So if you're joining us as an expert fitter or brand new to scleral lenses. Because of this increase that we've seen in the trends, there are so many ways that you can learn and get better and better at fitting sclerals. And we hope that today you'll take a few things out of this lecture to bring back to your practice. And we will be around at the end to answer any other questions. Chats will be live. We won't be answering them during the presentation, as I think Dr. Hamadi had mentioned, but we'll definitely get to it at the very end. Now, with our increasing level of technology that we have available to us, that we're going to go through during this presentation, it brings increasing complexity. So the more things that we have at our fingertips to use and to do, different materials to choose from, different pieces of the puzzle all put together, we've actually gotten to this level where we can create these increasingly complex contact lenses. The image you see is one of our patients here at Mission. And I mean, the thing looks like a crazy potato chip. There's holes in it, it's customized, the edges have notches, it is absolutely irregular. And that is a huge difference from where we've gone, even as recently as 5 years ago. As we increase in complexity, in some ways, technology makes things easier for us. In other ways, troubleshooting all of these different features, just more things that we need to train about, more things that we need to learn how to do and how to use. And because of the technology, our standard today is very different than what it used to be. And so, manufacturers in our current age have really improved our materials and lathing techniques. And so we're really grateful for that, because now it's basically, sometimes I feel like the sky's the limit. We can dream up, we can create now what we can dream up when it comes to these lenses for our patients. And so, it's kind of a fun time for contact lenses or for scleral lenses. Some of the tools to consider that are a little bit maybe newer technology that we're going to talk about include things like using endothelial microscopy as a predictor for success, or explaining failures. So we've got a case report to share with you that looks at this topic. Now, we've gone from kind of grassroots fittings, where we can call it that, whatever you want to say, old fashioned, which we'll get into, however you want to look at it, with very minimal equipment. And in fact, I'm going to guess that there are a lot of fitters out there tonight that come from clinics with maybe not every piece of equipment that you see on this slide. Maybe not everyone has a tomographer. Not everybody has scleral profilometry. That's very common. So there are a variety of different new tools, though, that we want to outline for you to make sure that this group certainly has some information about what is out there, whether you're using it or not. And for those that do have these tools, we'll provide some advanced cases and give you some ideas of how maybe you can elevate your practice and bring some new ways of using the tools to your lens design. We've really moved forward from only diagnostic fitting style into lenses that are designed based on impressions, scans, and we're even entering the era of artificial intelligence, which is very scary but exciting. AI absolutely is something that touches almost everything that we do in the future. Some things, that we do today in 2022, not just eye related, but, in all parts of our lives, have artificial intelligence certainly involved. We know this, and it's something that we will see more and more of. So we're going to touch on that briefly as well. Other advancements that are available, including things like multifocals and fenestrations, are things that we're going to go through as well in this presentation. So when it comes to, the old-fashioned fitting process. So we really want to talk about the tech. Anyone that knows me knows that I love the tech. It's been a lot of fun for the last, close to a decade here, working with the schools and in the clinic. Our office has, a lot of bells and whistles, which we're very proud about to be able to use to really optimize the way that we fit scleral lenses here for our patients. You know what? We absolutely also fit kind of the old-fashioned way without any tech. Sometimes equipment is down. Sometimes there are occasions where, you really do need to just use a diagnostic set. And we do that, honestly, probably at least 50% of the time are at Mission. We wanted to go through the process a little bit to give you a few clinical tips about, before we get into the tech, the old-fashioned process. So Andrea, or Dr. Lasby, seeing as I never talk to you at work, we work side by side, but it's been so busy, we hardly have a chance to catch up. I'm going to have you go through what you normally would do in a diagnostic fit, just to give everybody out there an idea of what are the things that are important, how can we use our technicians and that kind of thing.
Yeah, absolutely. Just like Dr. Morrison said, I had mentors through my residency, and that was almost 9 years ago now. And they said the same thing, you can't forget how to fit a corneal gas permeable lens just because these scleral lenses are coming out. And the same is true now. So we can't forget where we came from, so that we can know when to use the tech, when we need to use the new technology, and when we can kind of just say, you know what, this is going to be fairly simple. I can nail this on my own. So the first thing that you can kind of decide, whether it's, you're just starting out with scleral lenses, or whether you're in a business that has a lot of support, a lot of technicians to help you, certainly, follow the fitting guide is the biggest thing. We want to take a look at your HVID, determine the best diameter, and then you're going to determine the best fitting guide. Now, some people you can actually have your technicians learn that. So they can start looking at your topographies. They can start looking at your HVID and actually say, you know what, we're going to put this lens in based on the fitting guide. I'm going to start them here. And then your technician can do all the work for you. So if you don't want to put in that lens and take out the lens, because it does take a lot of time away from you to do these things, then have that technician learn how to put it in, take it out confidently. Have them swap on over to the OCT, take a central vault, and then see, okay, is it in my practitioner's sweet zone, as we say? So anything pretty much like under 300 for me and over 150 is like my sweet zone. So I want to take a look at a lens where the central vault looks like that. Another thing to think about is generally, and we'll talk about this a little bit later, most of my fits are going to have toric haptics. So I put them in diagnostic lenses right away with toric haptics. So for example, you can actually talk to your manufacturer, the lab that you work most with, and say, you know what, can you just send me a fitting set where every single lens in the fit set is a toric edge, has a toric haptic to it. And so that has really saved me a lot of time as well, because I do much more toric haptics than I do spherical at this point. And then once you kind of find that good vault and you have that staff member, they can take out the lens, put it back in, adjust the sag on their own until they've kind of got that right fit. Then you can look at the lens. So it is not uncommon that my technician is actually with the patient for 15, at least 20 minutes before I see them for the first time, because they're already on it. They've got everything that they need. And oftentimes when I see the lens for the first time, that's the last lens I need to see on the patient's eye. So it really does make things faster for us. We book patients about an hour for new fits, but I would say that, I really only need to see that patient total time in my chair, maybe 15 minutes. Mm-hmm. And so what's really nice about that is I can double book with other, patients. I can see another contact lens follow-up in there. I can see a medical urgent red eye, or even kind of slot in an eye exam. So there's a way to be really efficient with this, especially because with, contact lens fits, you want to make sure that you're profitable with them at the end of the day. And so that's kind of like what we call old-fashioned way, which is essentially what we do presently for a lot of our fits. And, when that hits a wall, then we're going to talk to you about what we're going to do for the next step. What's the future? What are we moving towards? What's becoming more popular with the technology?
On that note, our technicians are really our greatest secret weapon, mm-hmm. because without them, and it takes training. So it takes a long time of, putting in the time with them ahead of time, that infrastructure, so that they can actually handle those to start your fits for you. As far as diagnostic fitting sets or putting lenses on an eye to figure out that refraction. So yeah, technicians certainly are super valuable, of course, and our staff really as a frontline in so many ways, putting time into them first, making sure they're totally competent and qualified to be able to help do those basic steps that Andrea mentioned, getting a lens on the eye, looking at the sagittal height. Oh, by the way, when you evaluate with a slit lamp, this is a debate I get a lot. Patients ask me, or patients don't ask me this. Other doctors ask me, how do you evaluate with the slit lamp? Do you like white light, blue light? When you have a lens with fluorescein, say the OCT's full, say, it just happened to me yesterday, it was too full and I wanted a measurement, I wanted it now. Slit lamp is great. And so yes. What do you use? White light or blue light? Both.
So what I'll do is I'll grossly put a huge blue light over everything, and I'll just quickly look for clearance all around. I'm looking for touch. I'm looking, is there limbal clearance all the way around? And then I'll put on the white light and I'll bring that beam down, put it on about a 45-degree angle or so. And then you can really measure, especially if you know the thickness of the cornea, the thickness of the lens that you're dealing with, then you really can see, okay, where is that fluorescein getting a little tight? And really with that white light, it's the best way to be accurate with your measurement. So if you don't have an OCT, the best way to be as close as you possibly can guess is with white light, because blue light, you will miss it, especially when you're looking for really small 20 micron limbal clearances, you'll miss it on that. So it's nice to kind of look at it in gross detail, but really when you're looking to kind of take a true measurement, we want to look with white light. Mm-hmm. All right. So with basic fitting considerations, we just talked about kind of diagnostic lens fitting. We're going to go over empirical as well, which is more based on things like scleral topography, for example. So we're going to talk about that a little bit later as well. But when you look at that empirical fitting, the nice thing about it is oftentimes, whether it's, let's say, you're doing some sort of digital freeform lens or an impression-based lens, you're going to be faster with that fit. Pretty much no matter what, it's nice to get a diagnostic fit where you nail it in one or two lenses, but it's not the norm, I would say. And so definitely, empirical, it's going to be more expensive for the patient, but also they'll be able to save their time, and time is money for many patients. So the other thing is that it's nice always, like even for those empirical fittings, we want to put a lens on to kind of see what vision's like, what's the potential there. And so it's nice for them to have that diagnostic fitting so that they know, how's this going to feel? Like you could describe this huge lens to me, and that can be very intimidating. And so it's nice to actually put a lens on the eye, especially for your ocular surface disease patients. So for anyone with dry eye, they're going to know right away if that lens is going to make their symptoms better or not. So definitely, we always put a lens on for those patients in office on fit day. And we won't just kind of order something empirically without seeing a lens on the eye. And again, for the fastest fit, you just want to use that data-driven digital impression-based designs, which we'll get into. But again, you can still do the majority of your fits with basic minimal equipment, your slit lamp, your chronophotographer, and if you've got one in OCT, because that really speeds you up and makes it much easier for you. But definitely, the majority of our fits even still are probably not in that high technology. We have that availability, but the majority of patients do really well with just kind of general diagnostic lens, or we would say the old-fashioned way. Which is kind of scary to say the old-fashioned way because it's only, a decade old.
It's not that old. Right.
Yeah.
Oh, this reminded me of the other secret weapon. I think actually Dr. Habibi on Try Not to Blink mentioned this. What would you be trapped like on an island with your sclerals? What would be your one tool? People are saying things like slit lamp, and the one thing we're missing is sodium fluorescein for the old-fashioned way. So that's another tool, absolutely, that you need for doing the fits without the tech.
Yes,
yeah,
absolutely.
Which we all have in the office. So
yeah. So we're going to jump into our first case here. We've got cases spotted throughout this, so we can kind of go over real life sort of things. So this was a 32-year-old post-LASIK female patient who was coming in for dry eye symptoms. Her symptoms are really bad in the wintertime. Obviously, it's winter for a long part of the year in Canada, so that's a problem, especially when she's outdoors. She's previously tried pretty much every single dry eye treatment you can think of, and certainly her symptoms outweigh her signs. So there's a neuropathic component potentially of her dry eye because she doesn't look as bad when compared to what she says. So really there was no keratitis, just some mild, injection on her bulbar conjunctiva, a little bit of MGD. My biography showed a little bit of recession. Tear breakup time was pretty good, almost, full 10 seconds. And then Alkane did improve these symptoms immediately. So sometimes what we'll do is to say, well, scleral lenses work for this patient. If we put Alkane on and it makes no difference to the pain, it's neuropathic at that point. There's something going on in the nerve further back from the eye, and it's, we can't really fix that with a scleral lens. So that's kind of one little test that we like to do, but also putting on a lens and saying, how do you feel, is also a really good way to do it as well. So we're going to do a scleral lens for this patient. She's in to see us because she's tried everything else, but what do we start with? So generally from the studies out there, that your horizontal visible iris diameter does drive your lens diameter selection. Generally, the smaller you are with a lens, the thinner it can be, and then the less mechanical weight on an asymmetric sclera there is. So generally, you can be a little bit more spherical with your edge design if you're going a little bit smaller. But larger lenses are really nice when you want good protection, and especially for dry eye, it really helps to distribute the weight of that lens all over the sclera. So really, I always kind of describe this to patients as it's the difference between a wedge and a stiletto. You can kind of think, if you were going to have someone walk on you with a heel, which one would you want to be walked on with? Definitely the wedge, not the stiletto. That thing would hurt like crazy. So same thing, we want to distribute that weight of that lens over more sclera area just to make it a little bit more comfortable, especially for dry patients. So we actually went with a 19 millimeter scleral lens for this patient because we really wanted to protect as much of her eye as possible. And immediately she said, this is great. I can already tell, during the fitting process, she's like, this is already amazing. And these are the ones that like really make you feel good about yourself, because right away you're like, oh, I'm going to change someone's life today. It's amazing. And so now she's, been wearing this happily for over a year and been wearing it full time, which is awesome. But as a caveat to that, how big is too big? So can you go too large where you're starting to kind of create more complications than you're solving? So one of the things to consider is lenses do tend to decenter inferior and temporal. And part of the reason of that, if we look at where all of those where our rectus muscles insert into the eye, the closest gap is going to be your medial rectus. So on the inside of your eyes. It only inserts 5.5 millimeters from your limbal area. So you want to make sure that if you're going large, huge lenses, we don't want to impinge on that muscle at all. It could definitely cause more of a visual disturbance and be more of an issue for patients. But of course, this is where we move from maybe spherical toric, we go to quadrant specific, and if not enough, we go to more intelligent designs, and even that. Because if they do decenter down and out, you can be inducing prismatic effect as well, and that can create some havoc for some patients too.
Now, we have learned a ton about ocular shape, and to the point of kind of, at what point do we choose a haptic that is spherical? At what point do we choose a haptic that is toric, meaning that we have quadrants that are more similar across the vertical and the horizontal? Or at what point do we choose lens designs that are fully asymmetrical? Now, when we look at ocular shape, the way that we measure it, we can measure ocular shape looking at using, we'll say, the old-fashioned way. And it's old-fashioned is not a bad thing at all. It's one technique that gets to the same end goal, which is that beautiful masterpiece lens in the end. And absolutely, we can get there from multiple different ways. Now, when it comes to evaluating that ocular shape, to choose, that lens design beyond the size. So that's the first piece, is that diameter. But what shape do we choose? We can figure out that shape of a patient's eye by placing a known shape lens onto the eye with fluorescein under it and looking at that edge pattern to basically deduce. We can also measure ocular shape beyond the limbus all the way across out to a crazy large diameter today with tech. And it's pretty amazing. Now, using some of these tools, groups like the Scleral Shape Study Group have put out literature to describe larger groups of people and what their eye shape is, looking at what the norms could be. And of course, we need way more data globally on what, average ocular shape is. But one take home of some of these studies using this tech to really measure is that, most eyes really do have their own unique fingerprint. It's amazing in the clinic, sometimes for no good reason, one eye will be completely different than the other in haptic. I do have a spherical haptic on one eye routinely with a non-spherical on the other, or a toric haptic that's completely different. And again, majority of eyes being actually asymmetrical. That's one of the things that have come out of some of these studies. Andrea, how often are you using, a sphere, a toric, or an asymmetrical haptic right off the bat? Like, what's your usual go-to in the clinic?
Yeah. And so kind of, as I mentioned before, I go right to a toric immediately these days. When I did my residency 9 years ago, I remember going to GSLS actually and talking to manufacturers and being like, I am just fitting torics all day long, every day. And they would ask, hey, how often do you fit a toric lens? I'm like, 80% of my patients are in a toric haptic. And people were looking at me crazy. Like, what do you mean? How are you getting that much? Like, this should be maybe 20%. And I was like, well, what am I doing wrong? I'm just a lowly resident.
I have
I'm
to say,
something
that probably never change just because she's a perfectionist with fitting. So those edges, you probably had smears on people in those days and then you didn't like it.
Yeah, maybe. Yeah. I mean, I don't love a lot of posterior lens debris when you see all, kind of that tear exchange, which we'll get into in a minute. And so I went to torics right away. And as more research comes out, I think it was Chad Rosen in 2015 gave a talk and started to talk about how asymmetrical eyes were. And I was like, yes, like, I'm not crazy. We see a lot of asymmetrical eyes. So specifically torics, I start with them with every single lens. And sometimes I'll go back and be like, oh, this is weird. It's not fitting right. Let's go to spherical and it's better, which is great. But honestly, that's like 20% of my patients now. Yeah. I would say more in toric. And a lot of those ones, the nice thing about starting with a toric diagnostic is immediately I can start to adjust for quadrant specific. And it speeds up your fit time. It has you do less remakes because you can start to say, okay, if I'm 100 microns flatter on the horizontal, 100 microns steeper on the vertical, and I see that, oh, nasal is impinging more than temporal, okay, immediately I'm going to flatten that nasal even more than what the toric lens is. So it gets you to your end lens faster. So if it's possible for you guys to work with your manufacturers to actually get fit sets where you have toric right away, that's what I'd recommend. But yeah, I would say, I'm toric pretty much all the time at this point. And then we get into quadrant specific very commonly. And now even with the addition of impression-based or digital freeform, what do we say for our practice? Are we in those?
We end up with a lot of patients that have already failed out of other lens designs.
Yeah.
And so quite often we are doing probably a higher volume of freeform impression-based. We get some crazy cases in our area. And I think on average, it would be like a mix of, toric, quad, and then freeform being like a third of it.
Yeah, I would say right now, at least for my patients, freeform on maybe like 10%.
I'm definitely higher, just the way it goes.
Yeah. And so it just depends on kind of your practice and what kind of patients you're getting into. We're a larger referral center. So a lot of times patients have tried toric. They've tried other lenses with other practitioners and it hasn't worked. And so we put them into those designs right away. So just going back a little bit to just some practice pearls, when we talk about kind of the kind of present and what we're doing right now, definitely want to make sure that you're always addressing the surface wetting issues. So consider material. There's definitely those with really high decay, but also like good wettability now. So things are improving all the time. I mean, I guess we just had like Infinite come out. So you were having those decays nearing 200 at this point. So really, really good oxygen permeability, but just make sure in our practice, it makes a huge difference to put hydropeg coating on those, because once you get those decays so high, they're just not going to be as wettable. And so at least for my patients, I bet I'm putting hydropeg on 80% of my fits, if not more. But we also live in a very dry polar desert here in Calgary, very similar to Denver's climate. So it's very, very dry here. So we do the hydropeg coating on almost all of our lenses. Make sure one of the things that will really help you that you won't kick yourself in the butt for later is when you start a fit and you're starting to see MGD and you're seeing that anterior surface non-wetting and starting to see debris and oils in the tear film and things like that, start them on a treatment plan at that fitting appointment. Don't wait until a lens comes and see how they do. Just tell them this is going to work so much better for you if you are invested in actually keeping your lids as hygiene friendly as possible. Get them on warm compresses, dry eye treatment if you can. You can certainly kind of get to send them down the IPL and radio frequency train if you like, but definitely whatever you do, make sure that you start that early on and not as a secondary thought where they're blaming you and your fit instead of it's actually being their dry eyes. And then finally, as I alluded to earlier, one of the problems with having a toric lens that's not fitting properly or having those edge designs that are a little bit too flat is we get excessive tear exchange. And so how I always evaluate this is I have the patient come to our practice wearing a lens for 4 hours, and then I put some dye on the surface of the conjunctiva, usually on the superior because it's actually the most, least sensitive part of the bulbar conjunctiva. And so I have them look down, and usually where we see it for the most part is always superior for the majority of patients. And so you can see how the dye in these photos is just kind of leaking underneath the contact lens. And what you can do to help with this is, of course, align the edges a little bit better if you can, make some adjustments. And if you run into a wall there, you could add a higher viscosity drop like Celluvisc, for example. Just a couple drops in the bowl prior to filling with your preservative-free saline is usually what I recommend. Some patients find some improvements from things like autologous serum drops in there, and some find improvements from buffered solutions versus non-buffered solutions. So if you're looking at like Purolens, for example, sometimes going to a preservative-free saline can be helpful with that as well. So I'm going to pass it back over to you, and Dr. Morrison's going to take us through a couple more cases as far as, just what to look for in both in kind of normal fits, but also if you are doing more kind of impression-based and digital freeform designs.
This is kind of fun as we merge and go from, the old-fashioned pouring a real old-fashioned on that slide. That's my favorite slide of this presentation. It's kind of the trend as everything is really about merging knowledge and tech. And the way we're headed, the trend is more and more tech and knowledge. That's just what happens. It's not going to change. It's not going to go away. The tech is here to stay. And so at this point, we're really, you'll notice that things start to accelerate as well with some of the cases that we're going to talk about. We want to keep it kind of fresh so that there's cool things that you can see that are happening in the clinic and give you some ideas. The patient that is here, this is a topography of a 95-year-old female, one of my favorite patients since I came back to Calgary. I love her. She's so lovely. She's always feeling like she's bothering us by coming to the clinic. You know, her family drives her in and she's just lovely. And she came to us actually as a non-contact lens patient, had never worn a lens, with complications secondary to kind of a botched cataract surgery. She landed aphakic, also with some pretty bad corneal scarring. And what we realized later was endothelial decompensation all across her superior 1/3 of the cornea. Now, she also had double vision with glasses, of course, when you have a +14 with some SIL and a low power on the other side. So she wasn't great in glasses. A soft aphakic lens was not a great choice for these patients because, as a lot of you probably face, I know Andrew and I have talked about this a lot, you know, if we can use a soft lens, we will. Generally, the best vision that we expect out of a soft lens, including an aphakic lens, would be about the best correction available in spectacles. And in this case, with all this SIL, just what's available out there with a lens for her and with that corneal shape that was irregular, I did, because I thought it'd be easier for her, and it just didn't work. So I did a acuity potential test. So to the point of one of the most important things that Dr. Lasby had mentioned, why do we put lenses on the eye in the first place? Well, lots of reasons. To do the fit in the old fashioned way, we put lenses on the eye to show a dry eye patient what it feels like, to see if they can actually benefit from the lens before we go ahead and move them through the full process. And we also do put lenses on eyes, scleral lens diagnostic lenses, to assess the best vision. And that is very important from a disease management perspective, as well as to just, again, see if this is a worthwhile exercise for this 95-year-old to go through a hard lens fit. Now, also, I had tried a cornea lens too, because at one point after we started her scleral fit, I did start her with a standard fit with the diagnostic fitting set with a fairly small diameter lens. She was also teeny, so her HVID was really small. Her lids were really tight and small, and dexterity wasn't great. So I really tried to get away with a fairly small scleral lens. And in the end, I think we landed on one that was only about, I want to say 15.8 millimeters or something like that. But when I started and had her wear the lens for several months, it was good vision. No matter what I did, she would still get this kind of light feather touch across that superior cornea, because that's where her big scar landed. And we know that these lenses, due to gravity, the big belly hangs low, will decenter inferior. So that's the perfect mismatch. The most imperfect match is the lens going down and that big bump up top. She ended up getting persistent epithelial defect, and on an eye that's fairly neurotrophic, she eventually actually got discomfort, which takes a lot. Some of our neurotrophic cornea patients, they could have a crater in their eye before they feel it. And so she did eventually return and let me know that she was starting to feel a little something funny. And it turned out she had some pretty bad deep scarring, deep staining and increasing scarring, which then makes it higher and harder to fit as that scar gets thicker. So it was kind of not the greatest. And so we requested an endothelial cell count as well, because she also got a demo with her contact lens that she had, although the vision she was in love with. And that was one of the only ways that she felt comfortable driving to do her own daily activities independently. So we wanted her in something. And this was a great opportunity for us to try some new things. And so for this patient, we ended up refitting and used kind of the higher level tech that we hadn't used before. Now, we could have successfully done this with an impression. And in the era that we are today, we do have digital scanning tools that allow us to take beautiful maps that translate into a variety of different lens designs. So in the past, there's maybe one or two that would work with these scans. And now there are countless numbers of different lenses that we can choose from. And what we were able to do with a one lens, actually, is the shape was really great on one lens with a freeform design, was do a lens that was tucked in at the bottom with kind of an irregular location vault over top of the scar. We also use the highest DK material possible, of course, and put fenestrations all over it. So sometimes we'll fenestrate in a few spots, which we'll talk about more, but in her case, we put several across that top portion where she seemed to have the lowest endothelial count and the most complication. In the end, she was actually able to wear this lens successfully. Now, I did settle for like almost feather touch. It was the best I could do. So I actually see her really regularly. These patients that are high risk, that have had complications, you got to bring them back. Don't let them go for a year without checking on them, because she will not feel it before there's a big problem. And we've faced this. I've had tons of these patients, and luckily in our education for patients, we really stress safety first and foremost with any contact lens. And anything that seems out of the ordinary, we remind them over and over and over to pop back in, and red eye patients that wear contact lenses are seen on the same day at our office. So we're pretty lucky, although there's always complications. And so we see this patient every 3 months just because of her high risk, but everything's been great. She wears her progressive glasses on top of her contact lens, and she certainly feels safe, going about her daily activities at this point. So digital design was really helpful for her. And basically, again, the optic was not the issue here. It was purely the shape, and it was a shape that was not really achievable with any of the other modifications I had made in her previous lenses.
Now, Dr. Morrison, you talked about endothelial cell count. Is there a minimum that you prefer to see for contact lens success? When we talk about if you get those endothelial cell counts, let's say from a partner ophthalmologist, or if you have that in your clinic.
I used to be afraid a little bit, and because there was an old cutoff of, make sure that it's got to be, at least 1,000. And then I, have been very comfortable with, I tried for around 800, but in reality, there's really no black and white answer on that, because I do have patients that have higher endothelial cell count, like, 1,200 or 1,500 after surgeries, and they end up having edema for some reason. And then there's these ones that we have that have lower cell counts that somehow are successful. And I think it comes down to, a bunch of different things. Our bodies are systems. So other maybe health things going on at the same time. Why is your body rejecting something and not able to pump out that fluid? Different factors in how old is their button, and if they have a graft, or where are those scars located? And all of the cool things we can do with our special features in contact lenses today. So we have actually, I've got quite a few patients that have low counts that you got to watch them carefully, but that are very successful. Yeah. Do you know your lowest that you can think of?
Maybe I think mine 500.
So mine are, my lowest is probably maybe around 700-800, we'll say. So So actually, let's see what is this.
But that one's fenestrated too, and I know you're going to talk about that later as well.
Totally. So this patient was about 1,000, so decent. But a really good question. No right or wrong today. But the bottom line, it can be useful though if a patient's failing to understand why, and that kind of knowledge of what those cells are doing can also help us to see what kind of stress that we're putting on an eye that wears a lens. So doing endothelial cell count over time is sometimes helpful on eyes that are high risk, that you start to have concerns about, just to see if we are, causing decreasing damage to the endothelium by wearing a lens. Although lots of corneas will decrease anyways with age and with other kind of just normal parts of life.
And we'll often do pachymetry before we see the patient, before their fit even starts, and then after they wear the lens for about 4 hours, so that we can see, is their pachymetry increasing? Are they starting to get edema even before they start coming with the classic signs of, I see halos around lights and those sort of things?
When it comes to scanned or imprinted lenses, they really can optimize comfort on irregular eye shapes. And that is something that, I certainly find in the clinic. We often can sometimes more efficiently achieve stability, but we do need an irregular enough shape for the lens to be stable. So if we fit, say, a scanned or impression lens on a slightly asymmetrical eye, that's not really enough of a difference for it to lock and be stable. It's not much of an advantage over a standard lens with a regular haptic. But for those eyes that do have more irregularity, which is most eyes, to be honest, it can really help to stabilize the lens a little sooner just by mapping out that shape. Actually, in some cases, we're almost like too much of a glove fit, which is where you have to pay attention for, are we fitting too perfectly where there's no tear exchange and they're too hard to get off? And that's kind of some of the things that we face with our freeform designs today, which we mediate again with things like fenestrations and purposely putting a channel in here and there, or lifting an edge or something like that. I find if things are running efficiently with technicians trained properly to use the tech, absolutely all the tech improves our chair time. As Dr. Lasby was saying, in the office, we can have our techs, pull starting lenses. Now with freeform, or not freeform, with the tools that we have, profilometry tools and other types of topographers, which I'll go through. I actually have one tech. Her initials are BB. You know what I'm talking about. I was running behind, and I didn't actually ask her to do this, but she knows, she knew me. This is a patient that I had put some instructions in, but there's one piece I'd left out. She was able to actually go and use our profilometer to herself, a tech she'd seen me do it enough times, to pick a starting height of a lens. It was no guesswork. She knew exactly what height to start with as a non-optometrist, as our technician, just by pulling the data from, measurements that we had taken for this patient. And it saved my butt that day in clinic, let me tell you. So that was a big time save. And by stabilizing, getting those lenses stable faster, it really does offer, a quick ability to get to our more complicated optics, like for HOA, optic placement, for example, and other customizations. So what are HOA correction? What are HOA, higher order aberrations? Basically, there are specific distortions. This is a grid that shows a whole bunch of different things for all of us dusting off the optics 101. But there are specific distortions within the eye structure that can cause things like ghosting, halos, just basically optical distortion that cannot really be corrected to fully satisfactory by regular glasses or contact lenses. Now, sometimes aberrations can be caused by, different injuries. Keratoconus, for example, it's very common to have higher order aberrations in our patients that have irregular corneas, especially when the back surface of the cornea is so misshapen. And this can be very, very visually disturbing for patients. When we look at where we're at today, it's not as common to fit HOA lenses, I would say. Now, there are, again, a few things that we have to have in place before we even consider fitting an HOA lens. Number one is connection with a manufacturer that can actually do it. It will become more and more common. We're seeing it more and more. We're doing it more and more, but at the same time, it is really a small population of patients, because in reality, we get patients all the time that come seeking HOA lenses from us because they're convinced that they're suffering from them. Have you heard that before, where they're like, look things up online, and a patient that has keratoconus that has spherical, a spherical optic in their contact lens, or just wears glasses, has ghosting, and definitely suffers from higher order aberrations. And then we're actually able to effectively correct it just using a front surface toric or changing eccentricity. So it is a small population, but a really important population, because those that truly suffer from higher order aberrations, it is just often just drives them mad, because anything that they do, they just can't quite get that vision that they're wanting. And it seems to come along with a fair bit of, in my experience, emotional distress surrounding it. A lot of these patients are a little bit more anxious about it for whatever their reasons. Great candidates include these people that are kind of 20/20 unhappy. So, we're targeting patients that don't really have a lot of scarring, that do suffer from things like glare, halos, doubling, comet tail, for example, these weird starbursts, poor night vision. And this is all with 20/20-ish, like sort of happy-ish, but not happy vision, with the very best optical correction. So they're neutralized to the very best of the ability with a potentially front surface toric hard lens if needed. Poor candidates, just to stay away from these. Do not promise these people that you can help them with HOA correction. Lots of stromal scarring, even a little bit, I usually stay away from. Lens fits that aren't stable. Sometimes dry eye patients where it's not a smooth surface, it's pointless, because you're not you put an HOA correction in a lens, and if it's all covered in debris and getting junk on it or moving a little bit, it's never going to be satisfactory for them for that fine detail that is corrected with HOA lenses. Again, a few other things, like if they're planning to have eye surgery or, some other conditions structurally, definitely stay away from them. But there are patients that really benefit from it. Mm-hmm. And I wanted to share this because it's really cool. And the process basically is fit the very best lens, work with a manufacturer that can create HOA lenses or can put the correction into the lens. Once a patient is fit properly with their best fit scleral with the best optic possible on the planet, with front surface toric, spherical haptic, changing eccentricity perhaps, then we take a measurement on top with an aberrometer, and that data is translated into a very specifically placed HOA corrective lens. And I have had some really incredible experiences, not many, because relative to our huge scleral population here, the ones that actually benefit from HOA correction are so small, but they are so important. This patient literally runs around the city talking about our office. No other office could help him. And he says his eyes team better together. The eyes are working better. He wrote this all out for me on a piece of paper and gave it to me as his notes. It was lovely. And he really put thought into this. He's been paying attention to it. Less shadow of black lettering on white background. And normally a starburst pattern, and it was actually on his countertop in his one room in his house, was very visible. And now the reflection is controlled. So it's really cool that it works. But again, you have to choose the right patient to be able to apply this technology to, for sure. Speaking of tech, this is one of the cool, I love that Andrea is so into AI. It's kind of freaks me out. I told you before that I'm kind of like, ooh, it's like things you don't understand. It kind of is a little intimidating.
Yeah.
But I've heard you say many times before that this is where it's heading. In fact, I feel like I remember a couple of years ago when I first joined Mission, you talking about OCT measurements in the future and something like that. And,
Yeah.
you know,
for sure. I mean, even like if you do, for example, your RNFL analysis for glaucoma, it's comparing it to a normative database. That's technically AI. So AI is here. It's big in diabetes care. It's big in a lot of retina stuff right now. And there's no reason why it can't be big in contact lenses. And some people are actually starting to do this. So with when we talk about like AI, it could be something as simple as like a virtual assistant. When you have, call a customer service line, you get a chat bot. No one wants the chat bot, but that's AI you're talking to. And so, is there a time in the future when some of the consultants you call might just say, hey, you know what, based on what you're telling me, I can already recommend changes for you. You don't even have to talk to a human being, and we can just get that going for you even faster. That might be the simplest form of AI coming forward. But what's really cool is what's going on. There's a lot of, research going to this in Australia particularly, and I know there's some in the States as well, but it really can help determine our first lens success. And so it can help you determine like what vault is necessary right away, most likely diameter to succeed, and just really help with those decisions. Anytime you make a decision, AI could be applied, based on big data to make that decision easier for you. It can also really help. Where I'm really interested in seeing it help is, can it help consultants and doctors more accurately recommend fit changes? So even like impression-based lenses, even, the digital freeform lenses, there's still changes sometimes that we have to make. It's not a perfect process yet. And so even that, if you're like me, I send tons of pictures away to my consultants. I'm like, here you go. Here's all the pictures of the eye. Here's a movie of the eye, everything you could see. Do you agree with the changes that I'm making? And so where AI could help with that is if we start getting thousands of photos coming in and really starting to teach software how we do what we do, we can take images like you see here where you have blanching in a very small area, and you can say, okay, I want to make a microvault there, but do I make it 150 microns thick or 250 microns deep? What is the best option there? And AI can really help with that. It can also maybe help consultants help their doctors more as well, so that they can get you to that final lens faster. So it's all about time is money, and less exchanges, the better. So this is really where I'm excited to see some research go in the next few years. And it's not just sclerals. As you see there, it's already happening in Ortho-K. A new kind of paper just came out this past year about machine learning with Ortho-K and improving those fits. So it's only a matter of time before this comes, I think, and it's going to be a big part of everything that we do. But we talked about before, there's not one single way to a perfect fit. It's not just impression-based or just, digital freeform, and it's not just, diagnostically fitting. There's so many different ways to get a really good fit for a patient. And it's not always clear kind of what the best combination of technology is when you're managing your scleral lenses.
So we've talked a little bit already about like diagnostic trial fits. Just to highlight some of our customizations that are available today, it's pretty amazing what we can do. For power, some of the additions to our standard optic have included now the torque power that we can put on the front surface. We've always been able to do a bi-torque on the back surface of a hard lens, of course, but when it comes to the actual vision and the optic, it's usually placed on the front, then we can do multifocals. Elevation differences we've gone over. Vaults and notches are something that we really obviously still use quite a bit at our office, that's for sure. And there's ways that we design them manually. Even I remember back to, the resident, I'm so, grateful to have had so many great, we talk about our days learning from great mentors and how lucky we've been. So thank you to those mentors at our respective residencies. Honestly, it's been a ride from that point on, really, really great. And I remember actually drawing with a felt marker, like a Sharpie, to cut out a notch. Digitally now we can do everything, and it's really, really cool. HOA correction, and of course materials, coatings, and treatments are all things that are lens customizations available to us now, just to get into a little bit more detail. And all of these things certainly play a role. When it comes to diagnostic lens use, just in summary, trial lenses, sodium fluorescein, we can figure out what changes that need to be made by looking at the way that a lens that we know the shape interacts with the eye. How does it land? And that's, absolutely part of our practice with almost every single fit. Now we can also, the other way, which is, they merge together, but measuring first is the other method. And that's the way that we have kind of alluded to when it comes to the freeform digital scans, using technology to really get a good comprehensive view. So learning about the eye shape with deducing the shape, learning about it by measuring first, both are accurate ways that can get to the final answer. Of course, impression molds have actually been around for quite a long time and are very, very, very accurate when it comes to creating designs that are very, perfectly. We don't want anything to be too perfect because it's, really plastered on there. But in reality, I mean, it's the most perfectly aligned shape that we can possibly create is from those impression molds. Digital scans are catching up though, which is kind of a neat thing coming down the pipes as the tech gets better in translating data when we scan an eye, say, take a corneal topography or a full ocular surface topography. The limiting factor in the past has really been how do we get that data, all those pieces of information into a lens, whereas an impression actually has that shape, is scanned, and has just a different process. But all of these things are part of the fitting process, absolutely. Tools that we use include our OCT in our practice, molding we use, Placido ring extrapolation, so we can use a corneal topography and extrapolate the data quite accurately now for getting things like sagittal height of a lens. It's actually really amazing. Scheimpflug imaging is also a wonderful topography tool that now can also extend past the cornea. We use it in, to fit scleral lenses as well. And then profilometry, which is another ocular surface topographer. Now, when it comes to empirical design in the clinic, we can get the known shape without even putting a lens on using one of our scanning devices. And then we can actually use prior base curve and power to just order a lens empirically. I do it all the time. Those that we don't have that power ready to go, then we obviously have to put a lens on, a trial lens to see. And we work them up. So before we choose any lens design, get a corneal topography, take an ocular surface topography if you have it, pachymetry, all of those basic measurements. And by looking at this data, you can actually select, are we likely to have success fitting a quad specific or toric design? Or in this case, where we have the steep proud graft with that mid-peripheral space and a really irregular scleral shape, this would be an eye that I'd probably right off the bat recommend doing a freeform or a impression-based lens. We are in digital paradise today. And I love things like this because the manufacturers have come so far in creating these beautiful interfaces. They're very interactive. These are just two examples, but there are now quite a few different manufacturers out there that are using things like this to allow practitioners who really kind of are control freaks about their contact lens designing to have full control and get in there and really make those changes that they can see. We still use consultants a lot of the time. I know myself when it gets really crazy busy in the clinic, which is almost always, to do some of that work for you. So you can take it kind of as far as you want. We can, have them make a lens almost from start to finish. We can get in there and design it ourselves, or we can do something in between, just depending on how much time you have and what your experience level is. And so that's where tech can be really, really helpful. Oftentimes, aside from looking at ocular shape, no, not oftentimes, every time, we need to look at who the patient is too. So I usually talk about this when we're talking about fully digital and impression driven and looking at empirical designs, because we definitely want to also take into consideration who is this patient when choosing a lens design. Out-of-towners, patients that have had failed fits in other designs, I usually don't waste any time and I offer them something different. So we'll take an imprint and a digital scan on the same day. I find a lot of manufacturers that are offering, or not a lot, but there is benefit to doing both on the same day, just because if you have a failed impression and then, you have to go to your scan then, and the patient's already left the office, it's really helpful to have both. So if you are doing any digital scanning or impression based, I'd always recommend to do them both on the same day. And remember, whatever it is that you're using to measure your patient to build lenses, especially empirical design lenses, quality matters. You have to make sure that the data that you're putting into the system is good. And otherwise, the data that comes out of the system is not going to be good. Now, we've talked a little bit about this, so we'll just kind of continue on with a few last cases. But again, public service announcement, trial lenses are still useful, and we love the tech. Those are our the two things. Decentered optics or something. Andrew, are you using it? I think that we were actually just talking about a patient today. Tell us a little bit about how you do with decentered optics, because this is a really cool feature available when we're fitting sclerals. How often do you use it? Is it something that's, really common for you?
Not super common, but I do use it, especially when it comes to multifocals, because we do have that kind of little bit of decentration that works really well with some multifocals, and some multifocal manufacturers come automatically with that, as long as you have a really stable fit. So I'm finding better results with my multifocals when I decenter the optics, but you can do it for other reasons too, and just even single vision, for example.
Absolutely. Here's an example of digitally. So you can actually look at a lens on an eye and estimate by looking at where that pupil is and actually tell the lab, what did I see behind the slit lamp? today we can also do it in advance. So you can actually take a scan that will map out the pupil and the locations, put a simulated lens on, and kind of build the lens with a decentered optic in what amount using a scanning tool. Now, kind of our last focus point is going to be just looking at fenestrations. We've been having a lot of fun here at Mission looking at different ways to utilize them. And the two main reasons I would say that we would consider using fenestrations, which by the way, are not a new thing. Fenestrations are actually around a really long time ago, just used in different ways. Some practitioners fenestrate with larger fenestrations in a triangle shape. One thing that we're playing around with a lot here at Mission is fenestrations in multiple different points on the lens, depending on the relationship of where the lens lands on the sclera and where that limbal clearance zone is, to achieve a little bit better oxygen. And also a big one for me is decreased suction. It's something that has become absolutely obvious in almost every contact lens fit, every scleral fit, but especially post-surgical eyes. Pulling and pulling on an eye is never a good thing. And so if we can reduce suction, ultimately the outcomes are so much better. We do this by using fenestrations and channels. And also, again, as I said, we use the fenestrations and channels to improve oxygen delivery. What you see here is an example of a digitally placed fenestration. So again, digital world is here. We also have labs that hand drill them, and they both work equally well. So there's lots of ways that you can get fenestrations into your lenses. At Mission, we did a little kind of a series of case reports at GSLS last year, just looking at some patient outcomes with a variety of different types of fenestrations in lenses. Here's a couple of highlights. Here's a patient that had 75-year-old male, history of bilateral keratoconus and a bunch of other kind of problems. So has had corneal grafts and chronic perilimbal injection. Sometimes if patients aren't getting enough oxygen, they also develop neovascularization of the cornea that can cross in and compromise the graft, and that can be really dangerous for them. This patient also, in the slide on the far left, you can see that the patient started to develop a little bit of almost macrocystic edema. So not only that microcystic edema with showing up on pachymetry, was also getting where they'd had surgical junctions, fluid that was building up closer to the front surface of the cornea. So in this case, just a really quick example of how we treated this patient, placing 3 fenestrations that were far enough into the contact lens that they actually gave air to the cornea. If they're too far in the landing zone, then they sometimes help for suction, but they're not really effective for getting more oxygen. And in this case, the patient was a lot more successful. The neovascularization regressed after some time of wearing this lens, and everything kind of cleared up and was a lot healthier for this patient. Lens suction, no brainer. So patients with really deep eyes, this is, definitely not the deepest, but a 6,000 micron lens of any size is pretty deep. And this patient tended to have a lot of issue with the lens suction in prior lenses, and also had a high level of anxiety surrounding it. So again, a no brainer. These patients, I don't even mess around. Anybody that has a PKP, anybody that has any issues with feeling like there's lens suction after their first lens, I'm fenestrating everything, and it really helps to reduce that suction feeling and increase safety of the lens fit. Mid-peripheral edema, this is my last case study, and then we're going to close with a few last remarks from Dr. Lasby. One thing that we see a lot with our population that has quite irregular shape, including that steep proud graft. So this is a pretty, obvious example of an ectatic cornea. And the blue image that you see is a standard contact lens shape that's fairly symmetrical all the way around. And, with a lot of designs, there can be limitations. There's a lot that we can do with quad-specific toric haptics. It's really amazing in that limbal zone that we, in a lot of cases, can reduce a lot of that excess of space. This patient experienced, had lenses that were to the max ability of decrease in the limbal zone in a particular lens design. Great lens, but for this eye shape just wasn't really working because the patient started to experience mid-peripheral edema. So essentially they were great clear vision in the center, but if you look at the OCT, or pardon me, the pachymetry change analysis, we're getting mid-peripheral edema that can be very dangerous for that graft. And you can see on the OCT cross-section, just too much space in that area. So it's something else to watch out for. In this case, we ended up doing a changeover to, I think we did an impression or freeform in this case as well. And that really reduced that space and resolved things for the patient.
So just final considerations before we send it to some questions. There's really multiple ways. There's no one right way to get to the right endpoint. So know that, just if you don't have all the tech yet, that's okay. You can still fit the majority of patients that are out there and fit them really, really well, just as well as, a digital freeform lens for that patient. But for the ones where it doesn't work, then definitely it's nice to have more freeform or impression-based lens designs that are out there. Also consider your chair time and the patient's time too. So sometimes we look at, which option are we going to choose right away, and certainly consider time as well, especially for patients of ours that travel over 1.5 hours, anywhere up to 8 hours to get to us, or fly in. Yeah, for sure. And know that, you really want to be able to be well-versed in everything. So even if you don't have all this technology, know what the extra technology will do. It helps your patients so much for you to be able to tell them, listen, we don't have HOA yet, but it's coming. So maybe your next lens in 5 years is going to be even better. It gives them that light at the end of the tunnel, and they leave just feeling super happy that they're with someone who's keeping an eye on the future, that will always keep tabs on what's changing, what's coming. And then, of course, just know that both approaches really, we share that same necessity to evaluate that patient as a whole person, know their visual goals, their lifestyle, their dexterity as well, and their ability to be compliant with the safe scleral lens use that we always recommend, which is a big thing that I think is glossed over a lot of the time. So we know that there's a lot of you out there. Thank you, for joining us. And we've got a lot of friends out there, and they always ask us for a little kiddo update. So here's our little ones, and where they're at right now. It's been a long time during the pandemic since I know that we've seen each other in person. So lots has changed. Mm-hmm. So we'll head it back over to you, Roxana, and go from there.
Thank you so much, Dr. Morris and Dr. Lasby. This was an awesome lecture. Lots of things to learn. We do have a couple of questions. If you do have to jump off, just remember that there is a survey after the webinar. But just a couple of questions I want to go over. Let me see here. Someone asked if higher order aberration lenses are good for correcting vision due to the posterior corneal keratoconic changes. So I guess to see if that's what's pulling through to cause those aberrations.
Yeah, I always just measure it. So, and it doesn't hurt. Yes, it can, absolutely. And that's kind of what it's there for. It depends. There's a variety of different aberrations that show up. And so usually there are some that are a little easier to correct, and the lab that you're working with usually is the one to kind of take a look at the aberrometry on top. So to really find out what is happening optically, the best way that I know of is just to take the scan on top of the lens and then take a look at what shows up to see if it's the type of aberration that's actually correctable with the manufacturer that you're working with.
Awesome. So another question we got here was about putting the fluorescein dyes, because someone mentioned that they heard that putting it on the very front of the lens is better to check for any leakage versus putting it on the bulbar conj. Have you guys tried any differences, noticed any differences between the two, tried one versus the other?
I have. I still like superior because in 95% of my patients, they're going to get it superior coming through. So it just gets the dye where it's needed faster. And I just see it faster because I'm right in the room and I don't have time. But I don't know if you've noticed any differences when you put it on the center. I mean, I think either or is probably fine.
I put it on the top.
Yeah.
That's just what I do. Yeah.
Same.
I don't think it would matter as long as they're blinking a little bit.
Mm-hmm.
Awesome. Someone also asked, when using fenestrations, are you seeing fogging or mucus in the vault, or is in the chamber brought in from the outside?
Not often, to be honest. The one thing is if the fenestrations are too large and not placed correctly. One issue that I have had as I was learning a little bit was that they would actually get air bubbles. That's more common. In fact, I've had a few patients that have had less fogging with fenestrations that are not super large. I think a little bit of tear exchange is not a bad thing, but absolutely. I mean, if they're huge, you're very likely to get air bubbles and mucus getting into the lens, but not for me, not with fogging. That's usually not something that I see. Do you have fogging with fenestrations?
I would say air bubbles are the biggest thing. Mm-hmm. Make sure that they're small. I don't know about you, but what sort of diameters are you seeing with fenestrations that you like? Because I agree, they used to be big. I mean, when I did my residency, all my Jupiters came fenestrated unless I told them don't put fenestrations in. Those things were huge and they had a lot of complications. But the ones now are good.
Yeah, there's some cool studies and right, even not that long ago that I think Daddy Fidel and maybe Don Ezekiel had put out, and there's some really great examples of how those types of larger fenestrations are super awesome for getting a good big air bubble. It works for them. The one thing in reality is that we need more study. So anybody out there that's working with fenestrations, there's no set of rules in theory. So theoretically, what I see personally happening in the clinic is decreased mild edema, and sometimes decrease when we put customized spaces of even just a little bit more tear exchange from a fenestration or whatever else over those areas that tend to have, surgical sites with even a little bit of macrocystic edema. It certainly declines. So Obviously they're doing something. What is the right size? I don't know. So there's a couple labs that I work with in the fenestrations, multiple fenestrations I've been doing that are a little bit smaller. So like 0.2 to 0.4 millimeters. I don't know that I work with anybody right now regularly that I have lenses fenestrated larger than about a 0.4 or 0.5 at the most. That's definitely seems to do the trick, definitely for suction. And I've actually been sometimes patients fenestrating in odd sites. I would say definitely though, the most common is the 2. So like maybe at 2 o'clock, and I guess that would be what, 8 o'clock or whatever, or 10 o'clock, 8 o'clock, 10, 8's down here.
Yeah. But you can put them wherever you want.
Yeah.
So the nice thing too, I've had certain patients where they have, let's say, a penetrating injury on one part, and they tend to get a lot of like check on cross section, because sometimes they'll miss the macrocystic or microcystic edema that's happening right at like the wound area.
Mm-hmm.
And you'll start to get the separation of the epithelium. And so in that area, I will put it like sometimes in a really weird spot, because that's where their scar tissue is.
Yeah. And those ones need to be on stable lenses as well. So those ones that it's not centered. So if it's not equally weighted after, it's the same thing as placing a torque haptic or placing a microvault. You need to know the lens rotation where it's stable. Then you place your fenestrations wherever you want them. And if you're going to place them anywhere that's not symmetrical, so say if your patient is, you're saying you're putting them over a scar, which I do too sometimes, maybe over here, and you want a couple of them, however, then the lens has to be stable enough to hold them. Yeah. Otherwise it'll rotate.
Awesome. Okay. So I think this is our last question is, for patients with corneal ectasia, how do you decide if someone will be a good candidate for multifocal lenses, particularly if we can't measure higher order aberrations?
How do you know if somebody would be a good candidate for multifocal?
Mm-hmm.
Yeah, so I'll say what I do, and then I'd love to actually hear what you do, and then hopefully I'll learn something more too. Usually, my rule of thumb is that if there's any decreased vision with best vision with a hard lens, then we have that conversation about expectations, because sometimes it's not going to, they'll be a little bit more likely to lose even just a little bit of that clarity that they do have. So patients that are already visually compromised, I actually usually recommend that they wear glasses on top of their contacts. And then for patients that, I find I have a lot of patients with regular shape eyes that do really well in multifocal optics with hard lenses, both in hybrids and also in the scleral lenses. And I think, you just don't know until you give it a try. You can trial them with soft lenses as well, especially like you're saying, if you can't measure. I do not regularly measure for aberrations for multifocals. I just usually try it out.
Yeah, same. I will usually tell the patient, okay, here's what we're going to do. We're going to do your distance absolutely first. Here's a pair of readers to get you through, but I want to see what your best vision possible is. And let's say they're 20/20, 20/25, then I'll be more open to doing a multifocal with them. Again, any patient less than 20/25, I really want them to maximize their vision, and we will do glasses over the top. But if they do find that they are kind of like good, happy with the 20/20, still want to give the multifocal a try, no problem. At least at the very, least, you still have a lot of warranty period. Hopefully with your contact lenses, you can put them in a multifocal, try it out. If you don't like it, guess what? You still have your finalized distance lenses, and there you go. You're good to go. But I would always recommend finalizing your distance power, knowing exactly what that is before you play around with the multifocal. Because sometimes if you're playing around with the multifocal right away with your distance optics in there, it is way too confusing to know what part is going wrong.
Totally. It's frustrating. Have you ever tried to be like a hero, which I've done this? Patients from out of town, you're like, sure, front surface toric, multifocal, first lens, of course. And I'm always mad like that I did that. I often will even put a spherical power. Honestly, a lot of the time, even though I know they're going to need front surface toric, I think you're a little more liberal about, like, I know that you often will order a toric lens on the first lens.
Yes.
I often will go faster on my fit, then let it settle long enough to get an idea of that rotation that's really stable for me. And depending on how much it is, I might even just, opt for the step of sphere, and then I'll add the toric power on the second lens, depending. Yeah.
Awesome. Well, thank you guys. We appreciate you guys again for being here today and speaking to us and giving this awesome lecture.